welcome everybody. So proud to represent Dr. محمد الماحي, Assistant Professor of Obstetric and Gynecology of Medicine, Cairo University, with the topic HIV and cervical cancer. And cancer. Okay. تفضل حضرتك.
صباح الخير، أنا اسمي دكتور محمد الماحي، أستاذ مساعد أمراض نساء في القصر العيني. It's a great honor to be here for second time. I had and I'll talk today about cervical cancer. It's a very important issue because it has a great burden for the community, not only an economic one, but social and psychological. As it usually occurs at young age, so a patient at the age of 35 or 40 years old, cancer, a very aggressive one, how it will have a good quality of life for her and her family. So it is very important to negotiate and give treatment and prevention, which is more important for the issue. Fortunately, as normal cervix doesn't change to a cancer at once, but we have stages before, premalignant lesions. They are considered benign, but may progress to cancer. So if we detect these premalignant lesions and treat them, we prevent cancer. We have a small introduction about normal condition of the cervix. At the age of adolescence, there is an area of the cervix called the transformation zone. They are covered by columnar epithelium, some sort of initial type of epithelium, and at the age of adolescence, it changes by metaplasia to squamous cells and other cells. So these cells are active and they are changing. DNA is active. For any interference or irritation of this DNA at this period, critical period, it may change into cancer. The most important irritant is HPV. By naked eye, most likely you will see nothing. It is normal, these premalignant lesions. But when we take these cells and examine under the microscope, we'll see the abnormal features, atypical cells. On the left, they are normal. On the right, they are the abnormal cells. And we can classify them according to the aggressiveness of affection. If they are mild affection to the lower part of the epithelium of the cells, it's called CIN1 or low-grade lesion. But if we progress to the more and more depth, it causes CIN2, CIN3, or what's called high-grade lesion. High-grade lesions just progress to cancer. We must detect cases in these stages. Please don't go to the most right side, not for the invasive cancer. For the left side, it is still controllable and preventable. Diagnosis is usually, almost always, during screening. So this is why screening programs are very, very important. The patient mostly complains of nothing. So it must be detected by screening program. Fortunately, screening program is an easy one. And mostly, we can say it is not an expensive one, but its impact on the future is very important. Screening. We have variable methods of screening according to the resources available. Okay? We have cytological method, which just a piece of wood, which is called an iris spatula. We can take a smear, or بالعربي مسحة, from the cervix, and to put on a slide and to be examined under the microscope. This is a very simple one. the only barrier of it needs an expert cytologist، دكتور الباثولوجي اللي هيقرا السلايد عشان يديتكت الابنورماليتي. ده الاونلي بارير الكبير للموضوع ده. طيب هل في حاجه مور ادفانسد او حاجه ممكن to improve the accuracy? Yes. We can use two stains. One is called Schiller's iodine and the other is acetic acid. Acetic acid 3 to 5%, which is available in every kitchen. خل البيت. This is the acetic acid we use. Okay? But it's very easy. Via means visual inspection with acetic acid. يعني you just put acetic acid when it goes and paint the cervix and look at it. Okay? It's also inexpensive method. This is pap smear, which can be taken by just an iris spatula, which is a piece of wood, or a little bit more advanced method. It's called a broom, which can get cells, and also we can detect the HPV status of the patient. This is a via. On the right side, without acetic acid, we just put, look at by naked eye or even by colposcopy, while we talk about. On the right side, we just added acetic acid. Acetic acid stains the abnormal lesion white. It's called a C2-white lesion. For the young doctors, the old name we say leukoplakia. سمعتوا عن leukoplakia قبل كده؟ C2-white lesions? Okay. So it is just a guide. So, and if we have a white lesion, a C2-white lesion, so this area is abnormal. We must go to more advanced test, which will be the biopsy. But it is a very simple test. Put acetic acid on the cervix and look. This is another stain. It's called Schiller's iodine. And instead of putting acetic acid, you can put iodine. Normal cells are rich in glycogen. So they will take the iodine and stain brown. This is a normal cervix, completely normal. This one, this is the same patient with this acetyl-white. Okay? When we stain with the Schiller's iodine, at the periphery, a little bit brown, still normal, no lesion. But in the middle, stains mustard yellow, or in other words, this area didn't take the stain. So it's stained yellow. This is the abnormal region. This is the abnormal area of the cervix. Is it a diagnosis that this patient had cancer cervix or perineal lesion? No. It just guides us to the abnormal area to go for the more advanced or confirmatory test. A colposcope. The colposcope is just an instrument we can use to do what we did before with the acetic acid and Schiller's iodine, but with a magnification. So it gives us better view, but in low or middle income countries or very low resources, or even in Egypt or outside Cairo, in upper Egypt or whatsoever, it is not mandatory. VIA is enough. Please, young doctors, VIA is enough. Acetic acid. مفيش حاجة أرخص من كده. Iris spatula. حتة خشب زي التانج ديبريسر. هتحطها على سلايد والكحول وهتبص عليها بالميكروسكوب وانت بعينك هتحط اسيتيك اسيد وتشوف في حتة اسيت وايت ولا لا. فيها حتة اسيت وايت انت شاكك فيها خد منها بايوبسي. Very simple. Very simple. ومن مميزات التكنيكس اوف سكريننج دي it is easily reproducible. يعني سهل قوي واحد يعلم واحد بسهولة. مش تكنيك صعب محتاج كيرف اوف education عالي. طيب now we did a screening and from the suspicious area we took a biopsy and confirm the diagnosis. How we treat? According to the result of the pathology, we decide the treatment. If we have a pre-malignant lesion, very mild form or severe forms, low grade or high grade, easily treatable. We have two methods of treatment, either ablation, you just kill these abnormal cells, or an excision procedure. هنشيل الحتة دي كلها. مش هنموت السيلز بس، لا هنشيل. طيب. Who took the decision or which one to do to whom? If we have CIN1 or CIN2 اللي هو low grade or mild high grade, the rule is ablation. Ablation, we kill these cells by either laser or electrocautery, by electricity, or cryotherapy. Cryotherapy, we kill them by freezing. This probe or this machine has a knob inside and like a shoulder. We insert it inside the cervix. So the knob is inside and the shoulders will rest over the cervix. And we use liquid nitrogen to do freezing. It has a depth of freezing of 5 millimeters and the width of 5 millimeters. So we will kill abnormal tissue with depth 5 millimeters and width 5 millimeters. It is very enough, and the patient to follow up after 6 to 12 months. These are the ablation technique, but we have an excision technique for the high grade, or also it can be applied to CIN2 or CIN3. We remove this area, this abnormal area, we remove it totally. Either by cold knife اللي هو السكالبل بالمشرط اللي هو لو سمعتوا عنها قبل كده cervical conization. انت بتدخل بالمشرط وبتشيل الحته دي كون الحته اللي بره عن السيرفكس وايد 1 وجوه بتبقى الدايمتر اصغر فبنشيل كون من السيرفكس. مور ادفانسد او حاجه لو متوفره يبقى احسن حاجه اسمها ليب او ليتس. ده لوب الكتريك بيتحط على الابنورمال اريا وبنشيل الحته دي كاننا بنعملها شيفنج بنقشرها. ليب اختصار ايه؟ لوب الكتروسيرجيكال اكسجن بروسيدير، وليها اسم تاني اللي هي ليتس، الاثنين نفس المعنى اللي هي لوب electrosurgical excision of the transformation zone. This area of the cervix around the external os is called transformation zone. It cells change between columnar and squamous by metaplasia according to the hormonal status of the patient. It has an active DNA. Metaplasia means active DNA. Active DNA, irritation of active DNA causes mutation, causes cancer. So this is the procedures we can use for excision. Okay, we have between ablation and excision of pre-malignant lesion. If a patient is 45, 50 years old and completed her family, what to do? Still, hysterectomy, total hysterectomy is a choice, but not a first choice. Because it is a major surgery for still a pre-malignant lesion. We can do an ablation, follow up. If not treated, our residual lesion is still present, you can proceed to hysterectomy. If the patient is very anxious, she has a good family history for cancer cervix, she will be ordered. She will not accept a conservative management. She needs the radical management. The radical management is hysterectomy. But please, 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 in Egypt now, subtotal hysterectomy is highly prevalent. Don't do subtotal hysterectomy routinely. You will leave the cervix, which is the part which has the pathology. The patient is not cured. But unfortunately, you will give the patient a false sense of security. She had a hysterectomy. I'm fine. No, you still have the cervix. Okay? So please don't do hysterectomy except a total one. Okay. We'll talk now about invasive cervical cancer. So we had infection by HPV, which will remain dormant for 10, 15 years or whatsoever, started to do cellular changes. We have atypical cells, mild part, low grade, high grade, and now the patient is not screened, not treated, the disease will progress to an invasive cancer. Fortunately, in past years, cancer cervix is decreasing in front of endometrial cancer. Why? Because endometrial cancer is increasing because it occurs in old age and the longevity increases, life expectancy of women increases, so it increases. And cancer cervix have screening program and has prevention by vaccine, so it should have been declining. In Egypt, we have a problem because long time cancer cervix and HPV are related to promiscuous sex. Well, it's not true. Okay, it is a sexual transmitted disease, but not only a sexual transmitted disease. It is not related to promiscuity, but it is a disease caused by HPV. So please screen and vaccine. And this is one of the barriers, the great barriers Dr. Amal she must have faced a lot. No, احنا شعب متدين بطبعه، احنا ما عندناش المرض ده. We will find very, very, very different statistics. As Dr. Asim said, we have, it is in the 12th to 13th cancer among Egyptian females. Studies reveal that it's the 8th. Okay. Also about the prevalence of cancer of HPV in Egypt, about around 10%. Studies was revealing that 14.7% of Egyptian females have HPV, and another study showed that it's not more than 3%. I don't think 3% is true. 3% is very low. We have a lot. We have more. So this makes a denial to vaccine, denial to screening. We don't have a disease. Why do screen and why we give vaccine? Here, with the pathology, by naked eye, we can see aggressive lesion in the cervix, a big ulcer, bleeding, mass. Under the microscope, we have two main forms, squamous cell carcinoma or adenocarcinoma, according to what cell of origin it arises, and degree of grading, how much of the malignant cells resembles the normal tissue. If most of them are resembling the normal tissues, have good prognosis. If most of the cells looks away from the normal cells, so it has bad prognosis. Spread. One of the most important issues about cervix, it can spread to very important tissues nearby. Here is the cervix. When it spreads upward, spreads to the uterus, downward to vagina, but what is more important is laterally. Laterally, it will go to the ureter, bilateral, compresses the ureter. Back pressure change will affect the kidney. The commonest cause of death of cancer cervix is renal failure plus bleeding, if she has severe bleeding. But renal failure is a common cause of death because it can invade laterally the ureters or compresses the ureter that will affect the kidneys. Also, the spread is very rapid. The patient from a local lesion in the cervix to a spread to all around nearby tissues may take 9 months to 1 year. It is not a long time. Also, from the surgical point of view, gynecological point of view, cervix, also all cancer cervix, in addition to local spread, it spreads to what's called the lymph nodes. And the cervix has very, very rich lymphatic supply. So it spreads to a lot of lymph nodes. We have many groups of lymph nodes. paracervical, parametrial, obturator, iliac, internal iliac, external iliac, common iliac, para-aortic. It spreads to a lot of lymph nodes. Which this makes surgery difficult, or an extensive surgery, which makes post-surgical complications are more common. We have a staging of cervical cancer according to the amount of extension or spread. If it is local, just to the cervix, it's called stage 1. I will discuss a simple form of staging, because staging of cancer cells is very complicated. Okay? If the lesion is confined to the cervix, didn't extend to the outside the cervix, and not visible by a naked eye, it is a microscopic affection, just detected on screening. It's called 1A. وده يشترط ان انا عندي depth of invasion للستروما less than 5 ملم. ده عشان ما يروحش للليمفوفاسكولار سبيس، فيبقى كده الريسك اوف lymphatic سبريد قليل. لو هو اكتر من 5 مللي هيبقى 1B. لو خرج بره السيرفكس هيبقى 2. نزل فاجينا بس ما راحش لللور ثيرد يبقى 2A. راح lateral parametrium بس ما راحش لللاترال pelvic wall 2B. 3A وصل lower third of the vagina. 3B وصل lateral pelvic wall or either nephrosis. 4 distant spread lung, liver, bone, brain, or reaches the rectum or the urinary bladder. Staging here is very important because treatment strategies will be built upon the stage. But simple method, this is the staging. Here, 1 confined to a cervix, not visible, 1A, visible, 1B. Sorry, less than 5 millimeters invasion is 1A, more than 5, 1B. 1A, okay. Yes, 1B, visible. 2A, vagina not reaching lower third. 2B, parametrium not reaching lateral pelvic wall. This is the more important. This is the screening that we told before. Symptoms. Cancer cervix in early stages may be asymptomatic as pre-malignant lesions, or the most important symptom we must put in consideration in every patient complaining of this symptom, we must do a screening at least, contact bleeding, spotting, vaginal spotting after sexual intercourse. This is very, very important. Please don't neglect. I saw a patient had contact bleeding for 9 months, and she continued to receive treatment of infection, treatment of cervicitis, and at last she came for a colposcopy and biopsy. It was an invasive cancer cervix with parametrial spread, stage 2B. This is in cancer cervix a very advanced stage. 2B is a very advanced stage because the treatment will be very difficult. So contact bleeding is very important. The advanced cases, symptoms of spread posterior uterosacral ligaments or colon, we have back pain. Lateral will affect the kidneys, okay? And in very advanced cases, cachexia or very bad health, like any woman with advanced cancer. She will die, yes, she is going to die. Examination generally, you have pallor of continuous bleeding, cachexia. Abdominal examination, we will feel the kidneys with hydronephrosis. Local examination, when we see as cervix by naked eye, by speculum examination, we will see the lesion, so the ulcer, malignant mass, whatsoever. Special investigations. Investigations for the gold standard for diagnosis of biopsy. Take a part of this lesion or the cervix, examine under the microscope. Patient proved to be an invasive cervical cancer, so we have another investigation to detect the spread, either local or distant. Local spread better by MRI and CT. lung and liver can be by CT chest and abdomen. I think in NICE guidelines in England, they do pan CT, CT chest, CT and abdomen. In Egypt, no, we do just for the liver abdominal ultrasound. For a chest, we do a chest X-ray. But NICE guidelines, CT. Any routines and the routine pre-operative investigation for any patient undergoing surgery. Okay, a treatment, the actual treatment we will do. Prevention is the most important point of treatment. Please, prevention, prevention, prevention. Treatment انا هقوله بسرعه ومش كاتبه بالتفصيل لان انا مش عايز ان احنا اصلا نوصل ان احنا بنعالج كانسر سيرفكس. يعني our goal is not to reach a point I am going to treat a patient with cervical cancer, advanced or invasive cervical cancer. No, I want to just treat maximum a pre-malignant lesion. We'll go to the staging. Stage 1, it is a very, very, very simplified treatment plan. If we have a stage 1A, just cervix, not visible lesion, hysterectomy, pan-hysterectomy. If a visible lesion 1B, more advanced, we will have some type of hysterectomy is called the Vertimes operation. Vertimes involves removal of the upper part of the vagina, the whole cervix, parametrium, uterine body, tubes and ovaries, lymph nodes, in the pelvis. Okay? It is an advanced surgery with many complications. Once we got 2A, just cervix and the upper part of the vagina, now surgery and radiotherapy almost of equal efficacy, but radiotherapy takes the upper hand of less complications. برضو ده تبسيط مش مخل قوي بس بليز يعني الجمله اللي جايه مهمه. اول ما نوصل ل 2B يعني we have parametrium affected, it is a radiotherapy only. Surgery has very, very, very minimal role if the patient has severe bleeding whatsoever, like in minimal role, like in for cure we are going for radiotherapy only. Okay, for lymph nodes, for the tumor itself, and hysterectomy may hinder the radiotherapy. Why? Because two types of radiotherapy are used. First type is called the brachytherapy. The radiotherapy capsule is placed inside the vagina or even inside the uterus. So if I had a Vertime operation, this place will not be available for a brachytherapy. And the other type is external beam or اسمه teletherapy. ده ماشين بتطلع ويفز كأن بيضرب على التيومر رصاصة. بيبقى معمول علامات على بطن العيانة مكان الليمف نودز مكان التيومر واكسترنال بيم راديوثيرابي. For a panhysterectomy after stage 2B or more will give you one only opportunity for an external beam would eliminate the brachytherapy. 2B, 3, 4, all of this are treated only by radiotherapy and the patient will not be curable and will have many complications, bleeding, the complication of radiotherapy, immunodeficiency, pain, and all our treatment are towards these symptoms, palliation, palliative hemostatics, palliative pain control, whatsoever, but this patient will die. We just try to improve her quality of life, but she will die. We have two special cases of cancer cervix. Treatment during pregnancy. Cancer during pregnancy, unfortunately, it occurs at young age. Cancer discovered during pregnancy. If the baby is before viability, before 28 weeks in England, before 24 weeks, we will not wait. We will not wait the baby to grow up, fetus to grow up, and we reach viability, then start to treat. No. Treat immediately, terminate this pregnancy. We'll do a cesarean hysterectomy, open خرج بيبي وهنشيل اليوترس وممكن نعمل radical surgery during cesarean section or it will be a hysterectomy complete by, but the patient must be prepared as a non-pregnant one. Metastatic workup, CT, everything will be done. طب how was she diagnosed? Why during pregnancy was most likely the complication was a contact bleeding or HPV, venereal warts whatsoever. She went to a dermatologist. When he saw the genital warts, he asked her to go to a gynecologist or obstetrician for screening. Screening done by cytology, colposcopy, all of this can be done during pregnancy. And she was discovered as invasive cervical cancer, unfortunately. To treat the patient or wait for the baby. No, the mother is more important. If after viability, you do a cesarean hysterectomy also, but we have the baby, so he must be delivered or done in a place with a good neonatal ICU. This baby, he may be her first baby and last one. So he needs preparation. Stump carcinoma, cervical stump carcinoma is now very common. Because, as I said before, the prevalence of subtotal hysterectomy. You remove the body of the cervix, of the uterus, and leave the cervix. This part is removed, and we leave this part. For a forced bleep, it is important for sexual life and for urinary tract to function well. No. Sexual life after total hysterectomy is almost the same as subtotal hysterectomy. So this patient had a hysterectomy. I'm fine. If any complaint occurred gynecological, mostly she will not seek medical advice. I did a hysterectomy. She had a full sense of security. Cervical stump carcinoma is very, very difficult to be dealt with. If this part was removed, so this is the cervix. When the uterus is present, the upper part of the cervix is related to the uterus. When the uterus is not here, this part of the cervix will be related to the intestines. Very, very early spread. When cancer occurs, it spreads to the intestine very early. Surgery will be very difficult. Radiotherapy will affect GIT, will affect the urinary tract to have a very annoying complications. So don't leave the cervix when you decide to remove the uterus. برضو cervical cancer please انا مش عايزين نوصل لمرحله تاني دي المسج. Don't wait or don't leave the patient to reach an invasive stage. Please detect early. We have general health instructions. Avoid smoking and alcohol, a healthy lifestyle. Go use, practice safe sex, health education, vaccinate, please vaccinate, screen, stay informed and educated. By these methods, we will, inshallah, we can eliminate invasive cancer cervix. Thank you.